So let's dive a little bit deeper now. We've talked about medical therapy, we've talked a little bit about epidemiology, but let's get into the nuts and bolts here. And so you're in the cath lab, right? Or I'm in the cath lab. I think when we have straightforward focal epicardial disease, I think it's pretty clear the evidence, both anecdotally and scientifically, shows that treatment of that with a stent is extremely efficacious at relieving chest pain and improving quality of life. But over the last decade, with the appropriate use criteria, with pushing medical therapy before getting to coronary angiography, partly because of insurance issues, both you and I are seeing a lot more advanced atherosclerotic disease. Instead of this focal disease, we're seeing a lot of diffuse disease. And as you know, 1 in 5 patients actually comes with a completely occluded artery, which is a completely different kettle of fish when it comes to revascularization in terms of risk, and when it comes to how to treat these patients medically and post-procedure. So tell me about managing that group of patients, the more complex atherosclerotic patient.
I think that's sort of true everywhere, right? So some of this is probably from deferral of care. Some of this is just from the fact that our patients are older and have more associated comorbidities. Many of these patients are already post-CABG, which we all know seems to accelerate disease proximal to the touchdowns of the grafts. So there's a bunch of different factors that are playing into this, but the bottom line is that PCI in a type A lesion is quite different than PCI in a diffuse multivessel patient that's got multiple bifurcations and maybe a CTO. And doing these types of cases ad hoc without having a proper conversation with the patient and the family is probably not the best practice. I think that we tend to stage a lot of these cases because it requires a much more involved conversation with the patient in terms of what we can expect to get out of the procedure, because it's not as straightforward as a type A proximal LAD when you have diffuse multivessel disease with bifurcations involved. And also in terms of overall expectations for durability of the results, all of this needs to be, I think, discussed at length with the patient before we embark on these types of procedures, because we've all taken care of these patients where the results angiographically look reasonable, but the clinical results are, suboptimal at best. And setting expectations up front, I think, is important to make sure that everybody understands what we're getting into.
Yeah, I do exactly the same thing. I use a lot of analogies in my practice. So I tell my patients when they've got a focal blockage that basically it's a car accident on a highway, and once it's cleared up, the traffic's going to be back to normal. But if they have like more diffuse, high burden atherosclerotic disease, I'm like, well, this is kind of like a dirt road, and it's not so easy to rebuild the whole dirt road. We can maybe carve a path so that a car can go down it, but the likelihood of us ever getting to the point at which you can have the same flow as a highway is pretty unlikely. And I feel, using these simple terms with the patients or giving them analogies to help them understand what their atherosclerotic burden is really helpful. I take all my patients into the clinic, into my office, to show them the angiogram. I show them a normal angiogram first, and then I show them what their angiogram looks like to sort of help them put it into perspective. And I feel like something like that actually really helps them.
Yeah, no, I agree. I also think that it helps referring doctors understand some of our more thoughtful approach to this. Patients with multivessel disease, even if we have landing zones for stents that are moderately okay, the problem with those patients is often the runoff vessels are so poor that we end up creating situations where we haven't actually revascularized them. We've just made their epicardial vessel look pretty. And that's something that a picture tells 1,000 words. It's something that I think it's helpful both for the patient as well as the referring doctor to see what we're talking about here.
How's your treatment algorithm of sort of PCI versus CABG in these more diffusely diseased atherosclerotic multivessel disease patients?
Yeah, I think that for most patients that are relatively young and diabetic, I would always want our surgeons to have to take a look at it to see what they think they could offer, because unlike us carving up that dirt road, they're only going to interrupt a small segment of that coronary artery. So if they can find a place to touch down a graft, I think that they honestly cause a less harm to the downstream flow of that patient, as opposed to us stenting 60, 70 millimeters of vessel and embolizing a bunch of stuff downstream. So I think that if there's ways in a relatively healthy diabetic patient with diffuse disease to get surgery, that's always preferred. That's not what we typically see. We see a lot of 80-plus-year-old patients with lots of comorbidities that have poor targets. And for them, it's a much bigger challenge in terms of what to do and what's actually worth the risk involved. And that's where these conversations can get quite nuanced.
Yeah, it's if you think about the patient with obstructive coronary artery disease that requires treatment, I mean, it's a legitimate patient level burden, right? For first of all, they've got to deal with the symptoms. Second, they've got to deal with the procedures and the potential for repeat procedures. So it's a leaky faucet that might keep leaking. You have to tell them that. They have a lifelong medication load. So you can see how this really impacts their quality of life. It's their functional impairment, the psychological impact, and not to mention the financial burden, right? Coming to have a repeat procedure over and over again or have repeat investigations isn't without financial burden on patients. So I think we're doing a good job in interventional cardiology trying to figure out who benefits most from PCI and who may benefit less with PCI rather than just with medical therapy. Things like the PPG that are coming out, the pullback gradient. CT has been incredibly valuable to look at the overall plaque burden to see whether we can actually improve flow. Of course, the volume of the coronary arteries, all of those things play such an important role on whether or not we're going to be able to achieve our goals.